the first person, Snehitha. Have I got the name right, beta?
Yes.
Okay. And your topic is JOAG. And don't give your this thing that I am so and so from this. No, no. You just begin, so you don't waste your time. Go ahead.
Good afternoon, everyone. I'm going to present a case of juvenile open-angle glaucoma. This is moving. It's a subset of glaucoma between 3 and 40 years of age with autosomal dominant inheritance, a male preponderance, and 87% of patients are myopic. 3.3% of newly diagnosed glaucoma in India is JOAG. The most common involved protein is myosin protein, and it's less responsive to medications and often requires surgical therapy. A 45-year-old male came with diminution of vision in right eye since 1 month, which was gradual onset, painless, progressive in nature. He consulted elsewhere 10 years back and he was started on topical medications. He was on latanoprost and timolol in both the eyes and Dorzox in left eye. He had a very strong family history with his mother and his maternal uncle having the same complaints. So BCVA was done and both his eyes were improving to 6 parts with minus 4.25 diopter spherical and minus 3.50 diopter spherical in right and left eye respectively. On slit lamp examination, right eye, the lids had prolonged eyelashes and then the conjunctiva had mild congestion, the cornea was clear, the pupil was 3 mm, D plus brisk and C plus was sluggish, and the rest A's was within normal limits. ACVH grading was 3 and there was no cells present. Left eye had similar findings with just the pupil having grade 2 RAPD. On Goldman applanation tonometer done at 10 AM with all these topical medications, on right eye he had a pressure of 12 mm Hg and left eye he had a pressure of 28 mm Hg. The central corneal thickness was also done where right eye had 471 micrometers and left eye was 477 micrometers. Gonioscopy using 1 GM was done and all the 4 angles were having 3 of modified Schaffer's grading and there was no evidence of peripheral anti-synic present. Prominent iris processes were noted in both the eyes. On fundus examination, both eye media was clear. Right eye disc was 1.69 in size using correction factor and then the cup size was 0.6. The inferior thinning was noted and supratemporal and infratemporal RNFL defects were noted. In the left eye, the disc was 0.9 in cupping and then concentric NRR thinning was present. A gross RNFL defect was there. Bayoneting of vessels and nasalization of vessels was also there. So OCT RNFL was done. The in OCT RNFL mark, the wedge defects could be picked up in right eye and left eye and the inferior thinning in the right eye and all 4 quadrant thinning in the left eye was noted. C-Fields 24-2 was done and right eye was appearing within normal limits and the left eye had advanced glaucomatous changes. So we proceeded with the 10-2 C-Fields and in 10-2 there was altitudinal defect as well as some generalized focal depressions in inferior fields. So diagnosis of both eye juvenile open angle glaucoma was done and both eye selective laser trabeculoplasty was done followed by which left eye trabeculectomy was done using with mitomycin C as adjuvant under LA. Post-trabeculectomy, the IOP in the left eye was 8 mm Hg. So what is unique in my case? It's a very uncommon yet a serious condition affecting the younger individuals. SLT is a promising first-line treatment option and trabeculectomy in young patients has to be performed very meticulously. So it is very significant because it has a rapid progression and can lead to early vision loss. It has a strong genetic link and challenging to treat and monitor effectively. So the take-home message is that vigilant management is required to prevent the progression. A holistic and a multidisciplinary approach is very crucial to improve the quality of life and long-term visual outcomes as these can have psychological and social impacts on all the individuals. Thank you.
Very good presentation. Dr. Bhalla, would you like to?
Yeah, just one point. Why did you do trabeculoplasty before undertaking? The left eye was already 28 and after trabeculoplasty it just dropped by 2 millimeters and ultimately you had to do trabeculectomy.
Yes.
So why this intervening procedure?
So actually at the first visit the patient was not sure whether he wanted to be taken up for surgery when we asked we have to do trabeculectomy. So at that time because of few literature studies which suggest that SLT can also be used as an adjuvant in the case of trabeculectomy. We did SLT in the first visit when he came and in the subsequent visit when he came we planned for trabeculectomy when he was actually ready for the surgery.
Diagnosis. Do you think that you missed out on any history taking?
Yes, ma'am. All the negative histories were taken. I asked about steroid intake in form of inhalers or any topical medications and also history of trauma to rule out any traumatic glaucoma. And we also, on anti-segment examination and as well as in gonioscopy, we can rule out this pigmentary glaucoma, pseudo-exfoliation glaucoma as well.
Apart from that, the RNFL OCT for the right eye is normal.
Other...
The RNFL OCT for the right eye is normal. Is that correct?
Yes, ma'am. All the negative histories were taken. I asked about steroid intake in form of inhalers or any topical medications and also history of trauma to rule out any traumatic glaucoma. Yes, ma'am. The right eye, that defect alone was noted, ma'am. The RNFL wedge defect. Yes, ma'am.
What were baseline IOPs?
The baseline IOP was, one second, oh, it's over. It was high in both the left eye. It was more high, ma'am. Right eye it was controlled because of the medications. And left eye, though on 3 topical medications, it was not controlled. It's around about 28.
Just one last question, I think. You've done very well, by the way. And I just wanted to ask you that, you know, you've done OCT.
Yes, ma'am.
But did you check the signal strength of that? And why was the signal strength only 4 or 5? Okay, doesn't matter. It's okay. Thank you. Thank you very much.